Professor.
Good morning, everyone.
Professor Ando. Lexi just wanted me to let you know she doesn't have Wi-Fi this morning.
Thanks, Gianna. Appreciate you letting me know. That stinks. I hope she is able to get it back eventually.
Yeah, she's trying, but it's not working right now. She shares Wi-Fi with her landlord, and it's not working right now.
That's yikes. Yikes. Thank you.
You're welcome.
How was that 285 exam everyone took? Did you have it?
Yeah, honestly, it wasn't even that hard.
Good. Good, good, good. All right, guys, just waiting on our last few people. Deshaun, you are a ball of sunshine. All right, guys, how are we feeling about the shoulder? Any questions before we move further down, distally down the arm with our elbow and forearm? Everyone's feeling great? Pectoral girdle, shoulder joint pros? All right. All right, we're going to keep moving forward. Also, just letting you guys know, I believe I have it opened. I have the quiz. So you guys are going to take the quiz on your own. Obviously, you're not doing it in class time. I have it set to open up, I think, right after class. I'm actually going in to check real quick. Right after class, and I'm going to keep it open until tonight. So you have until like 11:59 p.m. tonight to finish the quiz. So please get that done as soon as possible. It is on the shoulder, and the reason I wanted to get one more quiz in, is going to go towards your midterm grade. All right, midterm grade. So midterms are due tomorrow. Grades are due tomorrow. So I wanted to get this quiz in just so you had one more additional grade to hopefully help boost your grade. And yeah. So normally, as you guys know, lab is 50% of your grade and lecture is the other 50%. So they get averaged together. I don't know. I think for midterms, we are not doing the full like averaging together. It's just going to be like your lecture grade. I don't think lab is counted in on that, but I could be wrong. I'm trying to find that out right now. I really don't remember from past years. So if you see a grade and you're kind of confused by it because maybe you're doing much better in lab than you are in lecture, it's probably because we're just taking the lecture grades for midterms. And then your final grade is lab and lecture averaged together. Does that make sense to everyone? Okay. All right. Your next exam is a week from today. Yeah, next exam is a week from today. I will post up all the study information, the study guide that has exactly what the exam is going to be on. I will post it up to D2L right after class. And so get working, use Brianna as help, study help if you're confused with glenohumeral rhythm. But your next exam is a week from today. If you have any questions on that, just let me know.
Professor Arundel,
Yes, Nas.
in the email you said that you were going to explain that you're doing something differently for the exam.
Yeah. So, okay. Yep, you're right. Thank you for reminding me. So for exams, I'm going to have you guys taking it on your own time. However, I'm going to kind of do a similar fashion to how I've done my A&P labs. You are going to have to record yourselves taking your exam. Either record it via Zoom, record it on your phone, and you are going to submit your recording of you taking the exam to Dropbox. I feel like we waste class time a full day by having you take the exam during class time. So I'm going to keep it open from like next Thursday all the way like to probably Sunday. You're still, as soon as you open it, you're only going to have an hour 15 to take it. And again, you have to be recording yourself taking your exam. You're just going to submit that video or recording to Dropbox. Pretty simple, nothing too elaborate, but I wanted to let you know that you're going to have more than just Thursday to take it, but that's when it's going to open and it's going to close on Sunday. Is that clear to everyone? Thank you for reminding me now, as I completely forgot.
No problem. But yeah, that's good.
Okay. All right. Good question. So you will be recording. So you're going to have your phone angled towards you. At first, I'm going to type out kind of the instructions that you are going to need for. It'll be under the exam information on D2L. So you're going to, with your video recording yourself, you're going to show me your workspace area. So like you'll take your phone and show me that there's nothing around you. And then you're going to place your phone facing you while you are taking the exam to make sure you're not like looking down, you're not going back and forth between screens. And you're going to record yourself taking the exam and post that onto D2L. Does that make sense to everyone? Again, I'm going to type out the instructions so it's all very clear for you, but I wanted to give you a heads up so you have, because you have a week plus to kind of figure that out. So those of you who just popped in, your exam is a week from today. I'm at least opening the exam on Thursday. I'm closing it on Sunday. So you're going to take it on your own time. We're not going to take up class time doing it. And you're going to record yourself via Zoom taking the exam. And you're going to send it into Dropbox when you are finished. Okay. Oh, great question, guys, on the flashcards. Flashcards are still due Thursday. Since that is the first day of the exam, flashcards are due next Thursday. Great question.
For the flashcards, do we just take pictures of them, or
Yeah,
how do you?
I have pretty strict instructions. You are essentially going to be taking pictures, but you have to make sure everything's filled out. Your flashcards are signed, like, so you have your initials in the corner of the flashcards, and you're taking pictures of both sides to make sure they are fully completed.
Okay, thank you.
Yep, you could submit as many pictures as you need to. So say they don't all fit, say it's hard to see, that's okay. You can take as many pictures as you need to and submit them.
Okay, thank you.
Mm-hmm. All right, so we are beginning the elbow today. Elbow and forearm, very much more simple of a joint compared to the shoulder, which is really nice. It's a nice break from the length and the chaos and all the muscles of the shoulder. Elbow and forearm are way more simple. Okay, everyone see this? Oh, Jenna, yeah, it's posted. I will open it up for you. I guess it's not visible. Of course, it's not visible. There you go. Okay, here we go. All right, guys, so let's get started. Quick review. What type of joint is an elbow joint? If we were to classify this joint, how do we classify this as? Okay, very good.
Hinge joint.
Excellent, guys. It is a hinge joint. It is a hinge. So what motions occur at a hinge joint?
Flexion.
Okay, flexion. Flexion's one.
Extension.
Extension. Excellent. What plane do hinge joints move in? If we are doing flexion and extension, what plane is this in? Excellent. Yes, Cassiana, Tamara, Mani, excellent. Sagittal plane. Very good, guys. Sagittal plane with that frontal axis. Very good. I know these are all just reviews from a few weeks ago, but it's very good to continue bringing these things up and reminding ourselves, oh yeah, planes and axes, because they're going to keep coming up and they help understand the movement a little bit better every time we go through it. Great. So the elbow, the proper anatomical name for the elbow joint is the humeral ulnar. And we're also going to talk about the forearm today. Who knows? It's right there. The proximal radio-ulnar joint is what makes up the forearm. And that's where supination and pronation occurs. it's crucial for you guys to remember supination and pronation is not an action at the elbow. The elbow is its own joint. The forearm is its own joint. And the forearm is where supination and pronation occur at. Okay, little bit on our bones and some bony landmarks. These are more important bony landmarks that we're going to look at only because this is where a lot of our muscle attachments occur. So on the humerus, we have all of these really big knobs. So let's get my laser pointer. We have 1, 2, 3, 4, 5. We have 5 knobs at the end, or technically condyles, at the end of the humerus here. If we were to number these, I like remembering these by their numbers, just because it's kind of hard to tell them apart. So we have the capitulum and the trochlea. These middle components, number 2 here is the capitulum. 3 and 4 combined make up the trochlea. So the trochlea is more medial. So here's the rest of the body, midline, trunk of the body. Here's our medial side. The trochlea is more medial, and the capitulum is more lateral. So always remember trochlea, medial, capitulum, lateral. Then we have our lateral epicondyle and the medial. If this diagram here is an anatomical position, what side of the body are we looking at? Who can tell me what side of the body are we looking at here?
Is that posterior?
It is the anterior side. Sorry, left or right. So it is the anterior side. Okay, it is the right side. Good, Alex. Sorry, I should have been more clear asking. We are looking at the right side of the body. So anterior, anatomical position. We are looking at the anterior side. This is a right elbow and forearm because the medial epicondyle, remember, medial epicondyle is closest to the body. On the ulna, let's do olecranon fossa, coronoid fossa. Coronoid fossa is this smaller hole located on the anterior side. Olecranon process is the bigger hole located on the posterior side. The coronoid fossa allows the coronoid process of the ulna to articulate with it. So when we flex our elbow, the coronoid process on the ulna sits in the coronoid fossa. Just like when we extend our elbow, the olecranon process of the ulna sits in the olecranon fossa of the humerus. Already went over coronoid process on the ulna. The trochlea, the trochlear notch. The trochlear notch is this. Trochlear notch is this entire smoother segment on the ulna, and the trochlear notch is what articulates with the trochlea on the humerus. Our styloid processes, the styloid processes are located on the distal end of the ulna and the radius. And then with our radius, we have the very simple radial head. It's nice and round. And our radial tuberosity. What muscle did we learn about on Tuesday? Inserts on the radial tuberosity. Anyone remember? Our biceps brachii. Our biceps brachii articulates and inserts on the radial tuberosity. Remember, biceps crosses over the shoulder and the elbow. All right, continuing on, talking about the joints itself, humeroulnar joint, that is the humerus articulating with the ulna, and that again occurs between the trochlear notch and the trochlea. The humeroradial joint, that is the capitulum and the radius articulating. That is super minimal though. The contact between the capitulum and the radius is extremely minimal. That's why we really don't even consider this a joint. And then lastly, the proximal radioulnar joint. So the proximal radioulnar joint is here where the head of the radius rotates on the ulna. This location on the ulna here is called the radial notch. So the head of the radius rotates in the radial notch of the ulna. Again, that's where that supination pronation occurs. What type of joint classification is our proximal radioulnar joint? What is the joint classification?
Is that saddle?
Say that again, Deshaun.
Is that saddle?
That is not a saddle. Nope. Think about it. So if we have our radial head, it rotates on the ulna to do supination and pronation. What joint classification allows for rotation?
Ball and socket.
You know, Nas, you're not wrong. You are not wrong. Ball and socket does allow for rotation, but it is not a ball and socket. There's one joint classification that only does
Pivot.
rotation. Pivot. Very good. A pivot joint. Yes, pivot joint. I like where your head's at though, Nas. That you're not wrong. I never really thought about that. So I should say a pivot joint only does rotation. Excellent. So in anatomical position, so if we're standing in anatomical position and you pronate and supinate your forearm, that is occurring in the transverse plane with a vertical axis. Excellent, guys. At the other end of the forearm, I don't know why I don't really have a good picture up. So this is all the proximal end. So the proximal radioulnar joint. There is a distal radioulnar joint, which I believe we talk more about when we do the wrist and hand on Tuesday. So here's a lateral view, and here's a medial view. One of them, when you're visually looking at both sides, other than the radius, there's nothing too distinct about one side over the other. However, when we are palpating, it is significantly easier for you to palpate your medial epicondyle. So the medial epicondyle is much more prominent than our lateral epicondyle. Right here. Medial sticks out big time. Lateral is a lot harder to feel. So here again is that medial epicondyle. Let's look real quickly and closely to, what color is this? Right here. Everyone see this kind of shallow groove right behind the medial epicondyle? So if everyone is palpating that medial epicondyle, and if you put your finger on your olecranon process, everyone should always be able to feel their olecranon process. So here's your medial epicondyle, here's your olecranon process. There is this shallow groove you should palpate that sits right in between the two. That's this area. It's not labeled, but that is called your ulnar groove. So right here, that is your ulnar groove, and your ulnar nerve sits in between those two landmarks. So medial epicondyle, ulnar, olecranon process, the ulnar groove sits right in between. And again, that is where your ulnar nerve runs through. So if anyone has ever hit their funny bone before, when you bang your elbow down on a table, hit it on accident, that is normally either you're hitting the medial epicondyle or you're hitting your olecranon process, and it is causing that nerve to get irritated from the vibrations. Sometimes you are directly hitting the ulnar nerve, which is very, very painful. Okay. All right, let's move on. This is a good image of some of the ligaments, some of the main ligaments, which we're going to talk about at the end of the PowerPoint. Our annular ligament, which goes around the radial head. So it encloses that radial head to help keep it down when it rotates. The RCL, so the radiocollateral ligament, and our UCL is not there, but we're gonna get to it. Just the human cadaver, nothing crazy. They're not even good pictures, but it's just kind of showing you it closes the capsule. You can see the annular ligament pretty good here. Okay, movements. So we've already talked about at the humeral ulnar joint, we do flexion and extension. It is a hinge joint. These are some rough estimates on how much range of motion we should be able to get. So for flexion, if I'm starting at 0 degrees, if I bring my elbow to right here, what degree is this?
$90.
Good. This is 90 degrees. So you as a clinician should be able to eyeball, okay, they came from here to here. That's 90 degrees. Right here is close to about 115. And then I can go all the way down, and that's roughly about 130. That might be a bit of a stretch, about 130, 140 might be a bit of a stretch. So it's usually about 130. If we recall, the end feel is soft tissue approximation. That's because soft tissue, adipose or muscle, is stopping my elbow from continuing to flex. Then we have elbow extension. So we have, here is 0 degrees. So 0 degrees is a straight line. A lot of people are able to hyperextend. So if I start here at 0, but then I continue to extend, I personally have about 2 degrees of hyperextension. So I'm able to go past 0 about 2 degrees. Some people prefer to write that as a negative. It's all personal preference, honestly, but you'll learn in upper how to properly dictate that. Who remembers what type of end feel is extension?
Bony.
Okay, very good, Courtney. It's a bony end feel, aka a hard end feel. Excellent. Then we have at the forearm, the radial ulnar joint, supination and pronation. Remember, supination, our palms are up, where the anterior side is facing up. It's like if you are serving soup to someone, you can't serve soup like this, right? Supination, hands, palms are up. Pronation, palms are down. Now let's take a look here. Pronation, we only have about 80 degrees of pronation. The way we measure supination and pronation, this is neutral. So if my hand is like this, see how it's kind of straight up. So I'm not starting in supination, I'm not in pronation. This is neutral. You usually, when we measure supination and pronation, you have your patient holding a pencil or a pen, and you measure how much movement from this position to here versus this position to here. Why do we have roughly less range of motion with pronation as opposed to supination? Who can tell me the anatomical reason as to why we have less motion there? Anyone?
Doesn't the ulnar and radius like cross over each other?
Yes, Liz. Okay, very good. So the radius and ulna, I'm going to get them out really quickly. Our radius and ulna, they literally cross over, the radius crosses over the ulna. So here we have radius and ulna in their proper little homes. Notice the radius sitting in that's the radial notch on the ulna. And when it rotates, when it rotates and we go into pronation, the radius crosses over the ulna like this, and it comes back. So when we pronate, it crosses over and comes back. So when our radius crosses over the ulna, it's stopping you. That bone crossing and creating the X is stopping us from continuing over. Very good. Good job, Liz. All right. Moving on to some of our muscles. We already did the movements. Okay. We talked about the biceps with the shoulder, correct? I just want to double check. I'm almost positive I covered it in both sections, but I know we do a little bit more with the elbow. No, do we not? I'm sorry, guys. Yeah, okay. I thought we did. I usually cover it in both sections just in case. Since it crosses over both joints. So just to reiterate on our biceps brachii, it is a biarticulate muscle. Biarticulate, as we remember, crosses over 2 joints. So how many actions at different joints should we expect from a biarticulate muscle? it crosses over two different joints, how many actions should we expect for that muscle to create? Two. Excellent, Jenna. Two. Very good. So the biceps is interesting. It creates at least two different muscles. I'm sorry, two different actions. At least two. It technically does three. So we know the long head originates on that superior glenoid fossa. And then the short head comes up directly and originates on that coracoid process. Then the two origin tendons come down. We get two muscle bellies, and they come together to create one tendon, and that inserts on the radial tuberosity. Right here, radial tuberosity. So the biceps, when that insertion pulls towards the origin, we get shoulder flexion, elbow flexion, and it also is the primary supinator, which sounds super bizarre. Because of where it inserts on the radius, when that muscle pulls and contracts, it's pulling the forearm over with it as well and up. So it supinates at the forearm, flexes at the elbow, and flexes at the shoulder. Any questions on our biceps? Okay. Moving on to the, oh, Jenna, it is the musculocutaneous nerve. Thank you. Good call. Thank you. Forgot. Okay, moving on. What do you mean, Tyler?
Like I read somewhere that assists with internal rotation or external rotation. I'm pretty sure.
I mean, yeah, that pull would do very minimal. Actually, no, it doesn't insert on the humerus. So it's really, it doesn't have enough effort towards that action for it to even be like, it's not considered anywhere I've seen in literature, but it's probably because it doesn't insert anywhere on the humerus. I think it rotates naturally because of how it crosses over here and probably how it sits in that bicipital groove. But maybe it's a synergist for external rotation, but I don't think it's enough to consider part of its action. If you want to send me where you saw that and read that, please do. I'd be very curious, but I don't think it's enough of an action to be considered part of the biceps brachii action. Good on the biceps? All right, moving on to our brachialis muscle. The brachialis is our true elbow flexor. The reason for that, the muscle, it's much shorter. It's much shorter muscle, meaning the muscle fibers only go directly from that mid-humerus to the proximal end of the ulna. So it's a lot shorter than that biceps muscle. usually our shorter muscle fibers with this arrangement help create more force. It's a smaller resistance arm, right? If this is the axis and this is where the effort is located, that resistance arm is much smaller, making it a much more powerful muscle. So our brachialis, all of our efforts, 100% of the muscle's efforts go towards elbow flexion. So the origin, again, is going to be that mid anterior humerus. Insertion is the proximal. You don't need to go too crazy. Coronoid process of the ulna. So the proximal ulna. And again, the action insertion pulls towards the origin. And we get direct elbow flexion. You will see it on quizzes, on exams, what muscle is the elbow agonist for elbow flexion? Answer is brachialis. That is the agonist, and the biceps is considered to be the synergist. This is also the musculocutaneous nerve. Okay. Our third and final elbow flexor is going to be our brachioradialis. So the brachioradialis is going to be a synergist for elbow flexion. It is because of where it inserts versus, where it originates versus where it inserts. Our brachioradialis does not provide a lot of flexion help. It actually does way more elbow stabilization. So on the lateral side of the humerus, all the way down our lateral forearm is where our brachioradialis muscle is located. So when we turn, if you put your hand in a fist, turn it. So bring your forearm to a neutral position. So I'm not in supination, I'm not in pronation, this is neutral. When we flex our elbow in a neutral position, that is mainly the brachioradialis acting. When we are in anatomical position and we're flexing our elbow, that is more brachialis muscle. So bringing us to neutral. I believe, correct me if I'm wrong, I'm really not too savvy with like a lot of lifting exercises and techniques. If you have a dumbbell in your hand and you're lifting it in neutral like this, is this called a hammer curl? Anyone know this? No. Okay, I believe it is. I think it's called a hammer curl. Thank you, Jared. So again, we are in that neutral position and that brachioradialis is performing the flexion. So the origin is going to be the lateral condylar ridge of the humerus. So it is distal humerus.
Where is that?
Here's our humerus. Here is, you are viewing an anterior humerus, medial epicondyle. Here is that nice flat lateral ridge on the humerus right here. So that is where our brachioradialis originates. And it comes down all the way to the styloid process of the radius. Styloid process of the radius. So that's a long distance. going from here all the way down to here. Kind of like we've said before, longer muscle fibers generally provide more range of motion, greater range of motion, and they usually work more for speed as opposed to generating force. And that is where our brachioradialis is kind of classified in as. The nerve, so this kind of helps. Brachioradialis is the radial nerve. Radial nerve, it's all on the radial side. So that kind of helps. The radial nerve innervates most muscles down the radial side. So most of our extensor muscles, like our wrist, finger, and hand extensors, a lot of them are innervated by the radial nerve. Okay, any questions on our anterior elbow muscles that we've covered so far? Oops. All right, moving on to the posterior side. Okay, posterior side is our triceps muscle. The triceps is honestly pretty interesting. There are 3 heads to the triceps. So I think we may have also done triceps with the shoulder. I think it was briefly covered, but I don't know why I'm getting those 2 muscles kind of confused with the overlap of where I am in A and P right now. But it's good that we're covering it again. So the triceps has 3 heads. We have 1, 2, 3. We have a long head and then a medial and lateral. The only muscle of the triceps, so the only one of the 3 that crosses over the shoulder, is our long head. The other 2 tendons, they start on the humerus. So the triceps brachii is still considered a biarticulate muscle, and that's because of our long head here. Medial and lateral head, they only originate on the humerus, but long head is on the scapula. So the origin for the long head tendon is going to be on the inferior glenoid fossa. So up top here, what muscle did we just say originates on the superior glenoid fossa? We just covered it. Which muscle originates on the superior glenoid fossa? Okay, good, Mallory and Jared. The long head of the biceps. So this makes it a little easier to remember. The long head of the biceps originates on the superior fossa. The long head of the triceps is at the inferior fossa. So both long heads are in the glenoid fossa. Then our lateral, the lateral head is on the posterior lateral humerus. The medial head is on the distal posterior humerus. Keep those simple. All 3 come together, create one tendon, and the triceps inserts on the olecranon process. So the olecranon process is located on the ulna. It is this big portion of the ulna, aka our elbow. So who can tell me if the insertion is right here on the ulna, and we know insertion pulls towards the origin? What action occurs at the elbow with the triceps? Insertion pulls towards origin. What action do we get?
Is it extension?
It is extension. Very good, Angelise. We get elbow extension. So the insertion is here. Our origins are on the posterior humerus and the scapula. So if I always try and think about, if you can't figure out the line of pull, try and picture in your head, okay, I have to bring this insertion to the origin. So I have to bring my olecranon process to the posterior humerus. The only way I can do that is through extension. So elbow extension and shoulder extension. So that is the triceps. Remember, triceps is the antagonist to our biceps and brachialis. Triceps is the opposite. So shoulder and elbow extension. And the triceps is also the radial nerve. And our final elbow muscle is the cutest little muscle in the world. It is adorable. It is super tiny. It's pretty useless, but it's still a muscle in the body. It is called the anconeus muscle. And the anconeus, the nickname is the triceps little helper. So the anconeus originates off of the posterior lateral humerus. So right here, posterior distal humerus. And it will come to insert on the posterior olecranon process. So here is actually a pretty good view of the posterior side of our elbow. Where this is our olecranon process located on which is on the ulna, and then the humerus. So anconeus goes from lateral humerus here to posterior olecranon process. And the anconeus helps with elbow extension. Brachioradialis, Jared, was the radial nerve as well. Radialis, radial nerve. And then also anconeus is also the radial nerve. I purposely put these in the chat, the nerves, in case anyone needs to go back through and look to find them. But if I ever do forget, please tell me, because I'm human. I can be forgetful. Okay, continuing on. We are now moving on to muscles of the forearm. These are nice because the actions, the muscles of the forearm are named for their actions. So that makes it a little bit easier to keep them straight and remember them. So the first ones that we're going to look at are going to be our pronator muscles. So the pronator muscles, they do pronation. And again, so pronator teres is going to be our first muscle, and it is located on the proximal forearm. The following muscle you'll see is going to be distal. So pronator teres is going to be towards the proximal end of the forearm. The origin is going to be the medial epicondyle. So the origin of pronator teres, we'll keep it simple. This is a very, very large explanation. We'll keep it simple. It is the medial epicondyle of the humerus. And pronator teres will come down. Pronator teres will come down to insert on the lateral radius. So origin, insertion, and because it goes across the forearm from medial to lateral, it's going to pull backwards across the forearm. And that's how it pulls the forearm over. So from the medial side to the lateral radius, it goes on a diagonal across. So remember, insertion pulls towards origin. And it's going to pull the forearm over into pronation. The nerve for our pronator teres is the median nerve. The median nerve branches off of, does it? No, it doesn't. Median nerve goes directly down the middle of our forearm into the wrist. Ulnar nerve stays on the ulnar side and will usually innervate muscles on the ulnar side. And the radial nerve, as you can tell, sticks to the radial side, aka our thumb side. Our next pronator, pronator quadratus. This is another cute muscle. I'm not going to lie. It's tiny. It's in this nice little square shape. So quadratus, quad meaning four. It has four sides, making almost square. So it's rectangle. The origin for our quadratus is on the ulna. So it's going to be on the lateral ulna, lateral distal ulna. Because notice pronator quadratus is on the distal forearm and it comes over to insert on the anterior distal radius. So origin to insertion. Pronator quadratus, it just helps. As you can see, it's very small, so it's not producing a lot of force. Like, it's very, very small. So it's not producing a lot of force, nor is it going over a long distance, like a range of motion. So all pronator quadratus is doing is helping the distal forearm pronate. So pronator teres does most of the work, and then quadratus helps out that distal end rotate over. Pronator quadratus is also median nerve. Any questions on our pronator so far? Also notice both of these, pronator teres and quadratus, are located on the anterior forearm. Okay, moving on to our supinator. So the supinator is on the posterior side And the reason it has to be on the posterior side, because of its attachments to help, it reaches from the lateral to posterior. And so when insertion pulls towards the origin, it's going to help bring us over into supination. Remember, the biceps brachii is also probably one of the main supinators. I'll kind of show you that on the next slide as well. So the origin for our supinator is going to be the posterior lateral ridge of the humerus. So posterior lateral ridge of the humerus over here. And it inserts on the lateral surface, posterior lateral surface of that, of the ulna. Okay, so I'll kind of show you on this. I don't know how well you guys can see here. Okay, so here the origin is on the lateral ridge of the humerus, and it comes down to insert. I tried. Let's try it like this instead. Sorry, guys. Forget it. I tried. So again, supinator pulls the radius over from here. Pulls the radius over from here to this way. So if we're in neutral right now, and right here is my origin on that lateral posterior radius, and it's going to pull towards the lateral ridge. So if going from here to here, it's going to bring that radius over into supination like that. This one's a little more tricky. Sorry, my bones are not easy to cooperate with when I need all three at once, but working with the best I can here. So our supinator muscle is innervated also by the radial nerve. And as I mentioned, the biceps brachii is largely responsible for supination. So because of that radial tuberosity insertion, this I can at least show you. So here is radius and ulna together inside of, together articulating. That radial tuberosity is right here. So it is right here. So if the biceps brachii is coming down to insert on that radial tuberosity, when the biceps brachii pulls from here up, it's bringing that forearm over into supination. So if it's like this, it's pulling over and up to supination. So the biceps is the primary supinator, and the supinator muscle is the synergist. Okay, any questions on these muscles? So that's it. Like I said, the forearm and the elbow are pretty simple when it comes to the muscles. That's because it's a hinge joint. So it only has two directions of motion. It's uniaxial. So there's not a lot of muscle since it doesn't have a lot of movement to make. So therefore, we are going to move into our ligaments. Also, not too many ligaments as well, but some important ones we need to go over. So we are going to start on the ulnar side. So the medial side of the elbow. The UCL is your ulnar collateral ligament. I'm going to tell you guys this, and I need you to remember this for the rest of forever. Anytime you have a collateral ligament, they run parallel to each other. So collateral, your UCL, your ulnar collateral, and your RCL, they run on the sides, along the sides of the joint. So the ulnar collateral is on the medial side. The radial collateral runs along the radial side or the lateral side. Okay, so collateral means they are on the side. Not, Tommy, not on ligaments. Not on ligaments, just the muscles. The list of the muscles, I emailed out to you guys. It's also on D2L. It's been on D2L. So only the things on the list are what we need the flashcards for. So the UCL, it's also nicknamed the MCL of the elbow. So everyone's heard of the MCL in the knee. The UCL is also called the MCL of the elbow. For the sake of the class, let's just keep it the UCL. I think it'll keep it more straightforward in your brains. So there are three, let's get rid of some of this drawing nonsense. There are three different bands to the UCL. So we have 1, 2, and 3. And the first band is called the anterior band. The anterior band or bundle, but the anterior band right here, this is the most commonly torn band. So when you hear of UCL ruptures, baseball pitchers from throwing, that excess external rotation and that force, that decelerated force of coming through creates a lot of valgus torque on the elbow. So you commonly see ruptures of the UCL. And it's usually this anterior band. So the anterior band runs from the medial epicondyle of the humerus. So medial epicondyle. And it goes to the coronoid process, or the coronoid. This is the coronoid process of the ulna. But notice it's like on the side of the coronoid process. The posterior band goes from that medial epicondyle, and it kind of is a bit wider. So the posterior band goes from the medial epicondyle, and it's a bit wider of an attachment, going from the olecranon process along the trochlear notch. And then the third band is called the transverse or the oblique band. And that goes from our olecranon process to the coronoid process. So all three of these prevent valgus forces from occurring. So a valgus force, going to kind of, so here is my elbow. A valgus force means it comes from the outside and it is putting stress on our medial structures here. So the UCL, so the three ligaments right here, the UCL prevents excess valgus forces. So any force that comes from this way, the UCL prevents excess valgus forces. A varus force, so valgus comes in laterally and it affects the medial side. A varus force affects our lateral structures and it comes in through the inside. So this is called a varus force. Varus lateral. Valgus medial. Okay. So that is the UCL. We do not have time to show you. It's a good YouTube clip of baseball pitchers, professional baseball pitchers, blowing out their UCL. It's called a Tommy John injury. That is when the UCL ruptures. Normally, the times the pitchers throw it with such great velocity that they are rupturing multiple bands, but younger populations are known to just rupture the anterior band. Anyone here in class ever had Tommy John surgery or have ruptured their UCL? Oh, Jess, what?
Me.
Deshaun, you too? Do you have,
I
you both have
strained it during the season.
football?
Yeah.
Yikes. Jess, did you have surgery?
No, I just had to stop my sport because I didn't want to get the surgery.
Deshaun, did you have surgery?
No, Jamie patched me up.
Jamie's the real OG. He's the best. Yes, Tyler. Tennis players absolutely hurt them too. So anytime you come that overhead excess amount of torque that's occurring at the elbow here, that's creating. So when we do this, that is creating a natural valgus force that's coming through internally like that. We do see that a lot with tennis players since their forward swing, even an overhead swing, can be a lot of force on that elbow. Okay, lateral ligaments. Real quick, want to get through this. I know it's 10:45. Lateral ligaments, this is called the LCL complex. So on the medial side, we only had the UCL. The LCL complex is a combination of the RCL ligament, the LCL ligament, and the annular ligament. Okay? So the whole complex are three main ligaments. The RCL goes from that lateral epicondyle and it actually inserts in to the annular ligament here. So it comes in, dumb pen, comes in and inserts in the annular ligament. The LCL ligament, surprisingly, comes to insert on the ulna. So it goes from the lateral epicondyle here and it inserts on the ulna. And then the annular ligament, as we mentioned before, comes up and it keeps the radial head located in the notch. So when it rotates, that annular ligament allows the radial head to stay nicely in that notch. So all three together create the LCL complex. Okay. And the lateral ligaments, as I mentioned before, prevent those varus forces. I always remember radial. So the radial side of the body is the lateral side. R in radial, varus, there's an R in varus. So just a silly way I used to remember, varus forces come in medially, and again, they affect those lateral structures. All right, we did it. We got through elbow and forearm. Great work, guys. I know if you have any questions on upcoming assignments, I will update all the information onto D2L to make sure it is on the calendar for you. And make sure you begin studying. I will post the study slides. The study guide for you as well. But if you do not have any other questions, midterm grades are going to be out. Again, I don't know if I'm going to be merging lab and lecture for just the midterm grade. I'm going to try, but there's no promising. It's a matter if Professor David and Carver are able to get those to me. So again, no promises. So if your grade either seems lower because you were kind of banking on that lab grade helping you out, don't stress. It's still plenty of time. If there's anyone I feel that is really concerning with their grade, I will email you personally and we can have a chit chat. But remember, you have Brianna Montoya to reach out to. She is our tutor. She is great and she is extremely helpful. So please utilize the resources that you have available to you. All right, guys, if you do not have any questions, I want you all to have a wonderful day, and anyone in lab, I will see you in about 10 minutes. Okay. Take care.
Quick question.
Sure.
It's about the homework. I wanted to know. Yeah.
For lab?
Yeah, for lab.
Okay. That's due in like 10 minutes.
Yeah, I just needed help on number 5. I wasn't really understanding it.
Sean, you're waiting now?
Yeah, I'm sorry. I did the rest of it.
I don't even know what the question is. Hold on.
It's 2 circus clowns having the same weight on and BOS, but one's on stilts, and it says which clown is more stable. I said the clown on stilts.
You haven't been given an option. You don't always have to do everything.
Hold on.
We're the same. You're not. And David, you're different.
I don't know why I can't find it. Hold on. The homework, right?
Yes.
It says it's lab 6 homework.
Yes.
Oh, I see it. Number 5. Sorry. 2 circus clowns have the same weight. And no, stilt is not right. Stilt is not right. So what is changing the guy on stilts?
Well, I was gonna say weight, but this says that they're same weight.
They are the same weight.
The more force.
No. So what does BOS stand for? Base of support, right? So BOS means base of support. But now, since they have the same base of support, meaning that their stance was the same, they're now being put on, this guy's now being put on stilts. So now that's changing his whole center of gravity since he's now taller. The center of gravity is what's normally located right in the middle of our bodies. When we change heights, when we get smaller, center of gravity comes higher. When we get taller, center of gravity gets lower, making us way more unstable. So for example, I showed you guys this example in class. Need something better. Okay. See my water bottle, right?
Yes.
Here's my water bottle on the table. When my water bottle is taller like this and standing up, it's easier to knock over, right?
Mm-hmm.
That's because the center of gravity is at a different location. Now, if I change my water bottle to this, it's rolling now. If I were to try and knock over my water bottle, how much harder is it to knock my water bottle over when it's like this?
Wait, you gotta use more force.
Yeah, I'm gonna need a lot more force because that center of gravity, since it's smaller, center of gravity is in a better location. That's why it's easier to knock things over, because our center of gravity is in a different location. So the guy on stilts, his whole center of gravity has changed because his height increased. Does that make more sense?
Yeah.
Okay. All right. Finish that up. Get that done. And I will see y'all in class in a hot minute.
All right. Thank you.
Bye.